Good day, my dears. And the topic of today's lecture is acute inflammatory diseases of the salivary glands and chronic inflammatory diseases of the salivary glands. I am glad to see you, and let's start. Salivary glands can be classified according to size as a major and minor salivary glands. The major salivary glands are of the three pairs, namely parotid, submandibular, and sublingual glands. There are numerous minor glands present in the labial, buccal, glossopalatal, palatine, and lingual areas in the oral cavity. The development of the parotid gland starts from 4th to 6th week, the submandibular gland at 6th week, and the sublingual gland, including minor salivary glands, develops at 8 till 12 weeks of embryonic life. The various developmental stages are, and you can see them on this slide accordingly. First stage is a bud formation stage, then epithelial cord formation, the next stage branching and glandular differentiation, canalization and cytodifferentiation accordingly to this slide, as you can see. The parotid is ectodermal, while the submandibular and sublingual glands are endodermal in their origins. The parotid represents the largest of the salivary gland, which is situated between the external acoustic meatus, between the ramus of mandible and sternocleidomastoid muscle. Each gland is encapsulated and is composed of fat tissue and cells that secrete mainly the serous fluid. The major duct of each parotid gland is called Stensen's duct, which opens into the vestibule of the mouth opposite the crown of the upper second molar tooth. And let's see the next slide, and you can see different pairs of major salivary glands. The parotid gland, being primarily serous in secretion, and secretes watery serous saliva. The submandibular glands are located along the side of the lower jawbone in the anterior part of the digastric triangle. Each gland has a minor duct called Wharton's duct, which opens on the floor of the mouth on the summit of sublingual papilla and the side of the frenulum of the tongue. Each of these glands is covered by a capsule which gives of mixed serous and mucous secretion in nature. Each gland has the secretory unit, which is mainly composed of acinous, myoepithelial cells, intercalated duct, striated and excretory ducts. And you can see I prepared it for you in this slide. And you can see these different anatomical and histological structures of major salivary glands. So, according to the duct, you can see excretory duct, then striated duct, and intercalated duct. And according to the structure of the acini, you can see different types of the cells according to the type of salivary glands. So, serous cells which are producing or secrete or produce serous liquid or saliva, mucous cells, and myoepithelial cells. So, according to this, that is understandable that the acinus could be serous, mucous, or mixed. These acini contain amylase granules in serous and granules with mucin in mucous glands and are responsible for producing primary secretion. The secretory granule is mixed salivary gland, contains serous, demilunes, capping mucous acinar cells, and they can be called as demiluners of Giannozzi or Heidenham, producing serous mucous saliva. And you can see it on the slide in this area. The ductal system of the salivary gland has a varied network, and as I said earlier, the three classes of ducts are intercalated, striated, and excretory, each with this different structure and function. The sublingual glands are the smallest of the major salivary glands, which lies above mylohyoid and below the mucosa of the floor of the mouth. And let's see the slide. Sorry, I forgot to show you these slides. Different structures of arseny, and these are mucous secreting cells showing mucogen vesicle. And you can see the structure of these cells. They are different from cirrhosis, and this one is cirrhosis, and you can see that the cirrhosis saliva is more fluent saliva and not so sticky. And according to the sublingual gland or glands, they are not covered by a capsule and are therefore more dispersed throughout the surrounding tissue. Their secretion are drained by many small ducts known as ravenous ducts that exit along the sublingual fold at the floor of the mouth. Sometimes few anterior ducts may join to form a common duct called Bartholin's duct. Their secretion being mixed in nature, which imparts into Wharton's duct. The sublingual and minor salivary glands are primarily mucous in nature. And in this slide you can see different locations of different pairs of major salivary glands, and we can see here with the yellow color submandibular gland and sublingual gland, and you can see that sublingual gland lies just above mylohyoid muscle and under the tongue. And other part of this slide, that is parotid salivary gland, which is a little bit in the other area than sublingual and submandibular one. Saliva. What is saliva? It is mainly secreted and produced by the salivary gland liquid. The total volumes of saliva secreted daily in an adult person is nearly 600 till even 1,000 milliliters, out of which 60% is secreted by submandibular glands, 30% by parotid, and only 5% by lingual or sublingual glands, and 7% by minor salivary gland, which with pH in range of 6 to 7. However, the salivary secretion is a reflex action arising from the salivary centers dependent on afferent stimulation. The sublingual gland and minor salivary glands spontaneously secrete saliva through the bulk of this secretion is nerve mediated. The normal average salivary flow rate ranges from 0.1 till 0.3 milliliters per minute. And you can see it on this diagram according to the different amount of volume of saliva and according to the pH of the saliva. And the next slide shows us the composition of saliva, and you can see that a lot of different components in saliva we can find, and a few words about it. Saliva is mainly composed of the following components, and you can see it on the slide. Electrolytes like sodium, potassium, chloride, bicarbonate, calcium, magnesium, phosphate, thiocyanate, and fluoride. Secretory proteins or peptides like amylase, proline-rich proteins, mucins, histatin, cystatin, peroxidase, lysozyme, lactoferrin, glycoproteins, lysozyme, and others are usually present in the saliva, and they also contain secretory immunoglobulins, and it is immunoglobulin A, G, and M. Organic components like glucose, amino acids, urea, uric acids, and lipid molecules. The other components that are present in the saliva are epidermal growth factors, epithelial cells, insulin, cystic adenosine monophosphate, binding proteins, and serum albumin. In addition, biologically active peptides such as leptin, ghrelin, and endothelin, which are identified in saliva, are of supreme importance to general health and also oral health in particular. In this slide, there is a scheme according to the composition of the saliva, and you can easily to see that two main types: organic substances and inorganic substances. And in sometimes we can divide gases. And according to the organic substances, enzymes. And I said about these enzymes and organic substances like mucin, albumin, protein. They are proteins, immunoglobulin, like a component of immunological system. Inorganic substances, that is understandable. They are different parts like sodium, calcium, potassium, and others. And gases, of course, first of all, that is oxygen, carbon dioxide, and nitrogen. Functions of saliva. A lot of different functions, and you can see these functions, all functions on this slide, and they are antibacterial, antifungal, wound healing process, depends on the components of the saliva, of the amount of the saliva. Saliva is a buffer, saliva is a mineralization is one function, like a demineralization, especially that is important when permanentes erupt. Food digestion, coating and lubrication, and antiviral, of course, component inside the saliva. And you can stop this slide and see all the components according to the saliva. I won't stop in this and explain because that is physiology and normal anatomy of the body, but only few words about functions of the saliva. Saliva mainly helps in lubrication from the movement of the oral tissues against each other, and the food aids in digestion, in a taste perception, neutralizes by its buffering action the bacterial acids, and thereby promotes remineralization by reducing dissolution of the enamel by inhibition of the calcium phosphate precipitate. The saliva overall protects the teeth, protects the teeth and the oral mucosa by the presence of immunoglobulins, tissue repair factors, and antibacterial system. And of course, if there is some problem with secretion of the saliva, that is understandable that it will influence or involve in these disorders or diseases all structures of the oral cavity as a first part or entrance of the digestional tract. Oral diagnostic approaches, if we suppose some problems with saliva or salivary glands to the patients which or with salivary gland disorders. First of all, of course, that is past and present history. To inquire about the history of patient who had undergone any surgery or radiotherapy or have any underlying systemic problems, the patient is under the medications or something like that. Second part, clinical examination. And you can see all this on this slide. A study by Navajo suggestions of 4 clinical measures to diagnose the hypofunction in the salivary glands. They are dryness of the lips and buccal mucosa, absence of saliva produced by the gland by manual palpation, and DMFT scores. And what is DMFT scores? I hope you understand. That is the sum of the number of decayed, missing due to caries and filled teeth in the permanent teeth. So that is a condition of the hard tissues of the tooth presence and absence according to the age of the patient. In the last part, that is imaging of the salivary glands, ceallography, spatial imaging, cellular chemistry, and biopsy and culture. That is functional diagnostic in order to understand if there are any problems and to do diagnosis and differential diagnosis for salivary glands disorders. I prepared for you different types of classifications of the salivary gland diseases and disorders, and let's see all of them, and then we'll stop in different most widespread acute and chronic diseases of the salivary glands. So this classification contains several parts, and first part that is developmental disorders of the salivary glands, and they can be aplasia, atresia, and aberrancy. So now in this cycle we won't talk about this part because that is mainly inborn disorders, or even if these disorders is not inborn, that is usually in patients who suffers with some tumors and tumor-like diseases of the salivary glands. The second part of this classification is inflammatory disorders and diseases of the major salivary glands, and they can be, as usual, bacterial cellular adenitis and the same acute and chronic types, viral cellular adenitis, and the most widespread, that is mumps, or cytomegalic inclusion disease as part of hyperviral infection, and post-irradiation cellular adenitis. The third part, obstructive and traumatic conditions. So it can be salivary calculi or sialolithiasis or cysts. Autoimmune disorders like Sjogren syndromes with Mikulicz disease as a part of this syndrome, hypertrophic, non-neoplastic, non-inflammatory conditions as cell adenosis. And the last part of this classification is neoplastic diseases and disorders like epithelial neoplasms, and they can be benign and malignant and non-epithelial, for example, lymphomas or sarcomas. Nevertheless, they are neoplastic and in most cases malignant one. Other type of classification by etiological classification of causes of cell adenitis. It can be infection causes, the same bacterial, different bacterial can be cultured from the pus if it's acute purulent cell adenitis, according to this classification. Viral and others. Viral, the same. It can be mumps, it can be HIV infection or hypervirus infection due to which cell adenitis occurs or starts. And others. What does it mean? Others, usually there are specific infection like actinomycosis or actinomyces and tuberculosis. Other etiological factors of sialadenitis: obstructive causes, sialolithiasis, ductal stricture, ductal foreign body, for example, fish bone, hair, glass bleed can gets inside the duct, and of course will cause different types of obstructive sialadenitis. And external compression of the duct, for example, denture flanges. Inflammatory causes, we've talked about this: drug-induced sialadenitis, that are the part of diseases of the major salivary glands. And for example, clozapine can cause sialadenitis. Of course, it will be drug-induced sialadenitis. Autoimmune sialadenitis and granulomatous sialadenitis. This slide shows other type of classification of different causes of sialadenitis. The same: acute infective sialadenitis, chronic infective sialadenitis, obstructive sialadenitis, immunoglobulin G4 related sialadenitis, lymphoepithelial sialadenitis, and granulomatous sialadenitis. And you can see in the opposite side of this slide, according to each part of the course, there is an explanation. And for example, granulomatous sialadenitis, according to the tuberculosis, cat scratch disease, and yes, it can be actinomycosis, sarcoidosis, amyloidosis, and granulomatosis with polyangiitis. Post-treatment sialadenitis. What does it mean? Usually that is post-radiation sialadenitis or radiation-induced sialadenitis. It can be radioactive iodine-induced sialadenitis or anesthesia-induced sialadenitis. That is post-treatment sialadenitis. Other causes: sialadenosis pneumoparotidis, necrotizing cell metaplasia, and subacute necrotizing sialadenitis. Unfortunately, the time of the lecture is limited, and that is impossible to talk about all these types of sialadenitis or diseases, acute and chronic diseases of the major salivary glands. There are a lot of specific information according to of each of them, but I try to prepare for you the main types and most widespread types of sialadenitis. And let's talk about them. What does it mean, sialadenitis? Sialadenitis is inflammation or infection of the salivary glands that may affect the parotid, submandibular, and small salivary glands. Imagine findings vary among unilateral or bilateral salivary gland enlargement, atrophy, abscess, ductal dilatation, cysts, stones, and calcification. And let's see the next stage. Next slide. Imaging is sensitive for detection of the salivary stones and stricture in obstructive sialadenitis. For example, immunoglobulin G4 sialadenitis appears as a bilateral submandibular gland enlargement. Imaging is helpful in staging and surveillance of patients with Sjogren's syndrome. Correlation of the imaging findings with clinical presentation can aid diagnosis of the granulomatous sialadenitis. Post-treatment sialadenitis can occur after radiotherapy, radioactive iodine, or surgery. Different imaging modalities are used in diagnosis of sialadenitis. Selection of imaging modality depends on the suspected course of sialadenitis. Radiographs are of limited value and can be used in suspected radiolucent stones, for example, and it is cheap method that is associated with radiation exposure. You can see on this slide radiographs according to the salidinitis of submandibular salivary gland, but we can't say that it is very informed, and we can easily ultrasound. Ultrasound is a cheap, non-invasive imaging modality that is used as a first diagnostic imaging tool in the assessment of cellulitis. It is a tolerable imaging tool, especially for young patients, but this technique is clearly operator dependent. It can detect diffuse and focal lesions and dilated ducts, areas of calcification and stones within the parotid glands or submandibular gland, for example, but it is not specific as, for example, radiographs. But of course, ultrasound in sometimes is essential to understand what type of pathology can be suspected. Cellography. Cellography delineates the ductal system down to four order branches that help in diagnosis of the obstructive salivary diseases and demonstrate the extent of salivary involvement in the Sjogren's syndrome. However, it is an invasive procedure, non-enhanced computer tomography. OCT is particularly useful when there is a suspicion of calculi, and contrast enhanced CT is indicated when there is an associated abscess and Sjogren's syndrome. The magnetic resonance or MR imaging is an expensive and sophisticated technique that is used mainly for assessment of the ductal system of the salivary glands by MR oscillogram. Short invasion recovery increases lesions conspicuity over routine span echo imaging by lowering the high T1 signal intensity. It is an excellent pulse sequence that is used for early detection of the cellulitis. And let's see this CT, and then we'll move on MRI. On this CT, we can see right submandibular area, and we can compare the right and left one, or symmetrical regions, and we can see that submandibular gland is enlarged and there is abnormal enhancement of the right submandibular glands. So that is difficult to diagnose what type of cellulitis is it. Of course, we need clinical examination, and I hope you remember about physical examination, which we can do in order to differentiate and then move on to the plan of the treatment and how to help for this patient. According to the MRI, you can see this slide is CT2, but that is contrast CT, and you can see the difference between contrast CT and CT without contrast element, and this CT is more specific. We can see different details according to the salivary gland or other structures. But now we are talking about salivary glands, and we can see that in this CT there is enlargement of parotid gland, and the first or A CT in this area, and I try to show it you with the arrow, and we can see that parotid gland is enlarged, that there is inflammation inside of the salivary gland, but there is no any pus collection, there is no abscess inside of it, because this enlargement is homogeneous. And a different picture is on the B picture. We can see with the arrow that there is a part of shadow inside the salivary gland. So we can suppose, we can't put a diagnosis only by this CT, but we can suppose that inside of this area there is some maybe liquid, maybe pus or something inside of the salivary gland. And with the history or anamnesis of the disease, with clinical symptoms and instrumental and functional diagnostic, we can see or we can suppose that that is acute purulent salidinitis or abscess formation inside the salivary gland. MR salography is used for diagnosis of stricture, gradient of Sjogren syndrome, and following up after radiotherapy. Diffusion weight MR imaging has a role of gradient of Sjogren syndrome and diagnosis of post-radiation salidinitis. Radionuclide imaging uses different types of radiolucents, uses different radionuclides, and mostly widespread is 99 technetium percentate, applied as an objective technique to assess salivary gland function, as it measures the degree of radioisotope uptake and excretion for major salivary glands separately. However, it is unavailable and it is expensive procedure. And in this slide, I try to find for you that is not MRI, that is CT, but that is PET-CT, and the same that is CT which use radioisotope in order to see the function of the secretion. So in this slide you can see the collection of this radioisotope in the submandibular sublingual salivary glands. Here we can see parotid and submandibular salivary glands, and the same different types of secretion according to the timing of the procedure. Initially, ultrasound investigation is used for assessment of patients with unilateral enlarged parotid gland, and the cross-sectional imaging, including CT and MRI imaging, for patients with bilateral enlargement or enlarged parotid and submandibular glands. So that is understandable that if there is only unilateral or enlargement of one salivary gland, that means that in most cases that is inflammation or obstruction. But if there is symmetrical inflammation or enlargement of salivary glands, we can suppose that maybe some common diseases or syndromes can be found in these patients, so we need to do more detailed investigation and assess the condition of the patient. The next slide shows us flow chart or algorithm according to the diagnostic tools for salidinitis. And you can see that first of all there should be some enlargement or some complaints of the patients according to the salivary gland. And if it's unilateral, we go to the ultrasound. If it's bilateral, CT or MRI. The next, according to the result of this investigation, if ultrasound found that there is a stone, of course we can do, for example, X-ray or CT and then remove the stone. If there is a stricture, we can do MR-cellogram in order to understand the reason or etiology of this stricture, and then deletion. It may be done by conservative methods or prescribing some drugs, or it can be done by surgery, for example. If it is found that there is abscess, of course, aspiration and surgery. Diffuse enlargement, according to the age of the patient, adults or pediatric, and then, of course, treatment. Bilateral, usually that is not simple inflammation. It can be, for example, immunoglobulins disorders or Sjogren's syndrome or HIV celladenitis. Of course, we need to do more detailed analysis and then maybe use biopsy or history of HIV in order to understand what type of celladenitis there is. And let's start the next part of this lecture according to different types of celladenitis. Acute suppurative celladenitis, and I decided that it will be understandable on, for example, acute suppurative parotitis, but that doesn't mean that submandibular or sublingual salivary glands can be inflamed with purulent secretion or with purulent exudation. Acute suppurative parotitis is characterized by parotid gland swelling and pus drainage from Stensen's duct. Dehydration, oral trauma, immunosuppression, even male gender and congestion in the parotid gland are known as predisposing factors. Suppurative parotitis can develop with retrograde flow into the parotid gland after colonization by microorganisms of the oral cavity or spread by hematogenous route from other focuses of infection. Infection of the parotid gland is more frequent than other salivary glands because of containing any bacteriostatic agents. Dehydration, stasis as a result of the decrease in production of the saliva or congestion in the channel also contributes to this situation. The diagnosis of acute suppurative parotitis is based on parotid gland swelling, pus drainage from Stensen's duct, with the growth of microorganisms in the pus culture. It is usually unilateral, but bilateral cases were also reported in the literature. 41% of cases may be accompanied by fever, and clinically erythema and tenderness can also be observed with the parotid swelling. So in this slide I tried to show you factors which can influence on diagnosis, and you have to ask according to the duration of the symptom and the number of the glands which are involved in the process, discomforts associated with the swelling, foul taste in the mouth, frequency of the symptoms, aggravating factors associating with meals or salivary stimulants, constitutional stimulants or symptoms, for example, like fever, viral prodrome, weight loss, systemic symptoms, joint pain, dry eyes, and mouth, in which you can suppose, for example, some syndromes, medical comorbidities, and a history of radiation treatment or previous chemotherapy. Laboratory findings are non-specific for acute purulent celladenitis. Increased acute phase reactants and neutrophils predominance can be determined, but they are not specific. In about half of the cases, serum amylase values may increase, and this is thought to be because of the immature salivary glands activity of neonates, if that is neonatal sialadenitis. Staphylococcus aureus is a responsible microorganism for 55% of cases. Other less common organisms are gram-positive cocci and gram-negative microorganisms such as the Escherichia coli, Klebsiella pneumoniae, and Pseudomonas aeruginosa, which can be the responsible factors in cases of secondary to sepsis or nosocomial infection. Anaerobic organisms such as the bacteroids and Fusobacterium are also more rarely known to cause acute suppurative sialadenitis and parotitis. Methicillin-resistant staphylococcus has been identified as a factor for acute suppurative parotitis in 2 of 3 cases in the article of different authors, but especially of Ismail. Early changes on ultrasound include enlarged hypoaortic salivary glands associated with the ductal dilatation. Abscess result in a relatively anaerobic and anaerotic focuses with fine and coarse enhorse to the large stage. Perigrandular inflammatory channels and changes in the reactive cervical lymphadenopathy are usually present. On CT, the gland is enlarged with diffuse immunohomogeneous pattern of constant enlargement. Abscess formation results in a focal area of fluid attenuation with the enhancing rim. Sorry. We need other slide. This one. The same. We can see CT with different types of acute purulent sialadenitis. And in most cases, CT typically demonstrate asymmetric diffuse enlargement of the parotid gland with high T to signal intensity that may be associated with a dilated duct on these images. The gland shows inhomogeneous enhancement with non-enhanced regions representing the dilated or dilated ducts, and you can see it on this picture in this area. Parotid abscess appears as a marginally enhanced lesion with characteristic restricted diffusion and low diffusivity of the abscess on apparent diffusion coefficient map. And in this part, you can see that abscess and the same in this area. In the differential diagnosis, trauma, lymphadenitis, hemangioma, adenoma, lipoma, parotid gland duct abnormalities, intraglandular abscess, and neoplasia should be considered. Determination of the parotid gland enlargement hypoaortic areas in the gland is evaluated in favor of suppurative parotitis. Rarely, intraparenchymal lymph nodes may occur. In our patient, in these cities, we found enlarged heterogeneous parotid gland reactive lymph nodes, and they were detected in the neighborhood, and also other causative parotid channel blocking factors were excluded. In the treatment of acute suppurative parotitis, firstly, patients should be hydrated. Empirical antibiotic therapy should be initiated to cover possible agents after obtaining pus and blood cultures. Cultures are necessary for accurate diagnosis and treatment. Pus culture can be obtained directly from the Stenson duct or by the needle aspiration of the gland. And I hope you remember previous slides, and I showed you in Stenson's duct the drop of pus, and this drop of pus may be enough for culturing and antibioticogram. Treatment for the isolated microorganism should be continued for 7 to 10 days, and in 94% of cases, aerobic gram-positive cocci and gram-negative bacilli have been determined as a factor so that antistaphylococcal agent combination with aminoglycosides is recommended for initial treatment. In the presence of methicillin resistance staphylococcal, vancomycin should be preferred. With proper treatment, significant improvement in 78% of cases and complete remission, more than 83% of cases within 24 to 48 hours have been reported. In patients who are unresponsive to treatment, parotid gland abscess development should be considered and ultrasound should be repeated. Abscess should be drained by surgically. The prognosis is usually good. Fistula formation in the gland, facial paralysis, mediastinitis, septicemia, and meningitis are known as complications of suppurative parotitis, but serious complications have not been reported so far. Mumps, the next part of our lecture, or epidemic parotitis. Mumps is acute contagious systemic viral disease, usually causing painful enlargement of salivary glands, most commonly the parotid. Mumps virus is paramyxovirus is the same group as parainfluenza and Newcastle disease virus. Parainfluenza and Newcastle disease viruses produce antibodies that cross-react with mumps virus. The virus has a single stranded RNA genome, and this virus can be isolated or propagated in cultures of virus human and monkey tissues and in embryonated eggs. It has been recovered from the saliva, cerebrospinal fluid, urine, blood, milk, and infected tissues of the patient with mumps. Mumps virus is rapidly inactivated by formalin, either chloroform, heat, and ultraviolet light. After 12 to 24-day incubation period, most people develop headache, anorexia, malaise, and a low to moderate grade of fever. And I tried to find to prepare you this information on this slide. The salivary glands become involved in 12 to 24 hours later with fever up to 39.5 and even 40 Celsius degrees. Fever persists for 24 to 72 hours. Granular swelling peaks on about the second day and lasts from 5 to 7 days. Involved glands are extremely tender during the febrile period. Parotitis is usually bilateral but may be unilateral, especially at the onset. Pain while chewing or swallowing, especially while swallowing acidic liquids such as vinegar or citrus juice, it is earliest symptom. It later causes swelling beyond the parotid in front of and below the ear. Occasionally, the submandibular and sublingual glands also swell, and more rarely are the only glands affected. Submandibular gland involvement causes neck swelling beneath the jaw, and suprasternal edema may develop, perhaps because of lymphatic obstruction by enlarged salivary glands. When sublingual glands are involved, the tongue may swell. The other ductal openings of the affected glands are edematous and slightly inflamed. The skin over the glands may become tense and shiny. So you can see it on this slide. As to the complications, mumps may involve organs other than the salivary glands, particularly in the postpubertal patients. Such complications include orchitis or orchitis, meningitis or encephalitis, and pancreatitis. About 20% of infected postpubertal males develop orchitis, that is testicular inflammation, usually unilateral with pain, tenderness, edema, erythema, and warmth of the scrotum. Some testicular atrophy may ensure, but testosterone production and fertility are usually preserved. In females, orchitis or gonadal involvement is less commonly recognized, is less painful, and doesn't impair fertility. Meningitis, typically with headache, vomiting, stiff neck, and CSF pleocytosis, occurs till 10% of patients with parotitis. Encephalitis with drowsiness, seizures, or coma occurs about 1 to 5,000 or 1 to 1,000 cases. About 50% of CNM's moms infections occur without parotitis. Pancreatitis, typically with sudden severe nausea, vomiting, and epigastric pain, may occur toward the end of the first week. These symptoms disappear in about 1 week, leading to complete recovery. Diagnosis of mumps. How can we diagnose? Clinical evaluation, viral detection via reverse transcription polymerase chain reaction or RT-PCR, and serologic testing. Mumps is suspected in patients with evidence of salivary gland inflammation and typical systemic symptoms, particularly if there is parotitis or a known mumps outbreak. Laboratory testing is not needed to make a diagnosis but is strongly recommended for public health purposes. Other conditions can cause similar glandular involvement. Mumps is also suspected in patients with unexplained aseptic meningitis or encephalitis during mumps outbreaks. Lumbar puncture is necessary for patients with meningeal signs. Mumps testing is also recommended for all patients with parotitis lasting more than 2 days without identified course. RT-PCR is the preferred methods of diagnosis. However, serologic testing of acute and convalescent sera by complement fixation or enzyme-linked immunosorbent is essential. In previously immunized populations, immunoglobulin M testing may be false negative. Therefore, RT-PCR assays should be done on the samples of saliva or throat washings as early in the course of the disease as possible. Other laboratory tests are generally unnecessary, and in indifferentiated aseptic meningitis and elevated serum amylase level can be a helpful clue in diagnosis of mumps despite the absence of parotitis. White blood cells count is non-specific, and it may be normal but usually shows slight leukopenia and neutropenia. In meningitis, CSF glucose is usually normal, but occasionally between 20 to 40 milligrams deciliter. Uncomplicated PANS usually resolves, although replace occurs rarely after about 2 weeks. Prognosis for patients with meningitis is usually good, although permanent sequelae such as unilateral or rarely bilateral nerve defense of facial paralysis may result. Post-infectious encephalitis, acute cerebral ataxia, and polyneuritis occur rarely. Treatment. As you can see on this slide, treatment is usually only supportive care. What does it mean? The patient is isolated, until glandular swelling subsides. A soft diet reduces pain caused by chewing. Acidic substances like citrus fruit juice that cause discomfort should be avoided. Repeated vomiting due to the pancreatitis may necessitate for hydration. For orchitis, bed rest and support of the scrotum in a cotton or an adhesive tape bridged between the things to minimize tension, or use of ice packs often relieves pain. Corticosteroids have not been shown to hasten the resolution of orchitis, so only supportive care. According to the prevention, we have a vaccine or vaccination with live mumps virus vaccine provides effective prevention and causes no significant local or systemic reactions. Two doses given as combined measles, mumps, and rubella vaccines are recommended for children. The first dose at age 12 to 15 months, and the second dose at the age of from 4 to 6 years. Chronic sclerosing sialadenitis or Kuttner tumor. And let's start the part of the lecture where the chronic sialadenitis will be explained. What is chronic sialadenitis? That is an inflammatory process that primarily affects the submandibular gland and presents clinically as a painful swelling. Histologically, chronic sialadenitis or chronic sclerosing sialadenitis demonstrates a loss of acinar tissue, dense fibrosis, which is mainly preductal and lymphocytic inflammation with lymphoid follicle formation in some cases. Chronic sclerosing sialadenitis is clinically characterized by a firm, relatively painful swelling of one of the submandibular glands, and that is a usual location of this type of sialadenitis. This disorder is characterized by plasmacytic and lymphocytic periductal infiltrate, eventually leading to the encasement of ducts with thick fibrous tissue. Histologically, chronic sialadenitis is characterized by preductal sclerosis, acinar atrophy, and infiltration of the gland by lymphocytes, which same studies have recognized as predominantly activated B cells with the subpopulation of the helper-induced C cells. The distribution pattern of these lymphocytes suggests that the response was immunological. However, cell lytids and mucous plaques were found in 30 to 80% of lesions. This association was meaningful for some authors, such as it was considered in a favor of cases and result relationship. Other possible etiologies of chronic sclerosing sialadenitis are ascending bacterial infection of the oral cavity and duct obstruction by foreign bodies. According to the SAFE, chronic sclerosing sialadenitis may progress through 4 stages, and they are histological stages. And you can see them on this slide. First stage, that is a focal chronic inflammation with aggregates of lymphocytes around moderately dilated salivary ducts containing inspissated secretion is present. The second stage, diffuse lymphocytic infiltration and severe periductal fibrosis are more marked. There is fibrosis in the center of the lobules accompanied by atrophy of acini. Next stage, even more prominent lymphocytic infiltration with lymphoid follicle formation, parenchymal atrophy, periductal hyalinization, and sclerosis, as well as the squamous and goblet cells metaplasia in the ductal system. And the last stage, cirrhosis like with marked parenchymal telos and sclerosis. That is like named burned out phase. Immunohistochemical studies of the lymphoid population in the chronic sclerosing cell adenitis revealed abundant cytotoxic T cells, especially near ducts and acini. The B cells reaction was less pronounced and largely restricted to lymph follicles. There was an intimate relationship between the T cells dominated inflammatory infiltrate and acinar and duct cells. The monoclonal and oligoclonal populations of cytotoxic T cells and their histological or histopathological even behaviors suggest that the chronic sclerosing cell adenitis may be the result of immune process triggered by intraductal epithelial agents. The lymphocytes that infiltrate the epithelial component of chronic sclerosing cell adenitis are mainly B cells and are often characterized by a lack of B cells to expression. The duration of symptoms before the patient seeks treatment is variable from 1 month to about 3 decades, and the induration and enlargement often leads clinicians to diagnose chronic sclerosing cell adenitis as a salivary gland neoplasm. And you can see at this MRI and the real situation that we can confuse, for example, chronic sclerosing cell adenitis and some benign tumor as, for example, adenoma of the salivary gland. Possible differential diagnosis of this entity include other benign inflammatory lesions of salivary glands, such as a simple chronic cell adenitis, granulomatous cell adenitis, necrotizing cell metaplasia, cell radiation effects, and inflammatory pseudotumor and benign lymphoepithelial lesions. One of the most common causes of chronic inflammation of the salivary glands is related to rheumatoid arthritis, which is consistent with immune pathogenesis. Usually, these cases do not demonstrate symptoms related to cell adenitis. However, cell lithiasis is the most common cause of cell adenitis in symptomatic patients. Histologically, various degrees of atrophy, fibrosis, and chronic inflammation are seen, but lymphoplasmacytic periductal infiltrate and fibrous incessant of the duct, which are typically of chronic sclerosing cell adenitis, are not present. The cases of granulomatosis cell adenitis range from infections to duct obstruction caused by calculi or malignancies. And according to the calculi, we'll talk about cell lithiasis. And according to the malignancy, we'll talk on the in 2 years when it will be a course of oncostomatology or cycle oncostomatology. Necrotizing cell metaplasia occurs mainly in the minor salivary glands of the palate and may be confused with carcinoma. In necrotizing cell metaplasia, an ischemic etiology uh, is thought to produce ulcerating lesions with partial necrosis of glands associated with regeneration and squamous metaplasia of the adjacent ducts. And of course, it can be easily diagnosed by cytological examination as a part of histological examination. The same chronic sclerosing cell adenitis, and we can see that that is a parotid gland, and we can see a capsule, so it can be easily confused with some other pathologies of salivary gland. Mikulicz disease is a part of a more complex syndrome known as Sjogren's syndrome, which also includes keratoconjunctivitis, xerostomia, and rheumatoid arthritis. The main histological features are lymphoid infiltration and epimyoepithelial islands, which consist of solid nests of prominent myoepithelial proliferation infiltrated by a mixed population of B and T lymphocytes. Therefore, the presentation and histological features of Mikulicz disease are different from chronic sclerosing osteomyelitis. And here you can see the major clinical symptoms of Sjogren's syndrome. Of course, I tried to find for you such severe cases or difficult cases with expressed clinical symptoms, but that is not so simple to confuse Mikulicz disease or Sjogren's syndrome with chronic sclerosing osteomyelitis. Sialadenitis. Chronic sclerosing sialadenitis is totally benign inflammatory lesion, and until now there have been no reports of malignancy. In fact, chronic sclerosing sialadenitis has often been removed and no additional treatment has been required. This disease is rare and most commonly occurs in submandibular gland or parotid gland. We present this type of sialadenitis in order to compare different acute and chronic inflammatory diseases of the major salivary glands. And the last part of today's lecture is sialolithiasis. And what is sialolithiasis? That is the most frequent course of salivary gland swelling affecting the major salivary glands, parotid, submandibular, and sublingual. The condition predominantly affects individuals of 30 to 60 years old and is more common in males. Initial management is conservative with various minimally invasive surgical options available for persistent cases. This activity reviews the presentation, evaluation, and treatment of sialolithiasis and highlights the role of interprofessional team in evaluating and treatment of this condition. Sialolithiasis is a benign condition involving the formation of the stones or sialoliths within the ducts of the major salivary glands and, of course, in the parenchyma of these salivary glands. It is the most frequent course, as I said, of salivary gland swelling with a reported incidence of 1 to 10,000 cases. In some cases, sialoliths can obstruct the salivary gland, leading to the inflammation, superimposed bacterial infection, termed sialadenitis, or in rare cases, abscess formation. There are various presenting symptoms with the most common benign clinical postprandial swelling of the affected gland and decreased salivary flow. In case of the larger salivary stones involving the distal submandibular duct or Wharton's duct, diagnosis is often possible based on physical examination. And I prepared for you these slides. Cases involving smaller stones within the distal submandibular duct or parotid duct or Stensen's duct were histologically diagnosed utilizing conventional radiography, cellography, and digital subtraction cellography. Modern diagnostic techniques involved point-of-care ultrasound, CT, MRI, and direct visualization with cell endoscopy. A variety of treatment options exist for cell lithiasis, including cell gougers, direct massage of the distal stones out of the duct, and other procedures including interventional cellography, lithotripsy, cell endoscopy, and surgery. And in this slide, you can see surgical removal of ductal stone, and that is transoral approach, of course, because the nearest way is used. The etiology of salivary stones formation remains elusive, and research into etiological factors is still limited due to the relatively rare incidence of this disease, which makes extensive studies difficult. Factors that are believed to affect salivary stones formation are divided into major groups: anatomical, affecting saliva formation of low duct stenosis or inflammation, and compositional, increased calcium content or altered enzyme function. Research in examining the geographic distribution of the hard water and salivary calculi formation demonstrated no correlation with an increased incidence of salivary stones in areas of increased water hardness. Studies examining the effects of hypercalcemia using animal models demonstrated no evidence of increased salivary stones with hypercalcemia. Additional factors such as decreased fluid intake and pharmacologic side effects resulting in decreased salivary production, for example, diuretic use, remain under the study. In recent years, tobacco smoking has been discussed as a potential risk factor for the formation of the salivary stones, and tobacco may induce inflammation within the salivary ducts and decrease the production of the salivary amylase. The exact pathogenesis of cell lithiasis is not well understood, but two dominant theories were suggested. One of them proposes that there are multiple internal microcalculi within the salivary gland secretory granules. When these microcalculi get secreted into the salivary ducts, they may act as a nidus for the formation of the larger calculi, alternatively forming a cell lithes. The second hypothesis suggests bacteria or food debris within the oral cavity enter the distal submandibular or parotid ducts. Over the time, this organic substrate may act as a nidus for the formation of the larger calculi. Histologically, cell lithes are composed of varying ratios of organic and inorganic materials within an inner core. The inner core is considered the initial cell lithes, with subsequently enlarged for the deposition of additional organic and inorganic material, forming the outer lamella or layers. Inorganic materials include hydroxyapatite and octocalcium phosphate, with hydroxyapatite being the most prevalent. The exact ratios of inorganic materials found within a cell lithe depend on the chemical environment in which it forms. Organic materials found within cell lithes include glycoproteins, cellular debris, bacteria, and mycoplasma polysaccharides. Studies utilizing scanning, electron microscopy, and polymerase chain reaction or PCR have demonstrated bacteria within cell lithes, predominantly Streptococcus genus. Bacteria are not present in all cell lithes, suggested they are not necessary for their formation. Clinical diagnosis of cell lithiasis can be challenging, as patients may not be symptomatic unless the stone obstructs the salivary ducts, termed salidinitis. Patients with obstructing stones will commonly present a history of unilateral salivary gland swelling and acute onset of the pain that worsens with meals. The physical exam will demonstrate asymmetric swelling of the affected salivary gland. And approximately 60% of parotid stones and 30% of submandibular stones will be located distally in their respective ducts. If large enough, these stones may be visually apparent on examination of the oral cavity. Salivary stones are typically demonstrate the oval or round shape and white or yellow color on visual inspection. If not visually apparent, the stones are usually palpable along the anatomic course of the affected salivary duct or gland. And on this slide, you can see X-ray with salivary stones or cell lithiasis, and we can easily diagnose them on such simple type of examination as radiography or X-ray. Cell endoscopy allows for direct visualization of the salivary stones and the salivary ducts, thus providing excellent sensitivity and specificity. In addition to aiding the diagnosis of cell lithiasis, clinicians increasingly use cell endoscopy for therapy and stone removal, given them advancement in endoscopic technology. Research has shown cell endoscopy to be the safe and effective alternative to conventional open surgical techniques with a more favorable complication profile. Additionally, cell endoscopy is performable in the outpatient setting utilizing local anesthesia. Management of cell lithiasis should begin with conservative measures, including massaging the salivary gland, non-steroidal anti-inflammatory drugs, and cell gurglers. Signs of infection, including cervical adenopathy, purulent discharge from the salivary ducts, or erythema surrounding the salivary ducts, indicate the need for antibiotic therapy. Further treatment is dictated based on cell lead size, number, and location if conservative management is unsuccessful. Mobile submandibular stones measuring less than 5 mm located within the distal duct should initially undergo management with endoscopy. Impacted submandibular stones within the distal duct and stones larger than 5 mm should have treatment with transoral duct slitting. Stones of 5 to 7 mm within the proximal duct or hilar region should receive initial treatment endoscopically. If this is unsuccessful or the stone becomes impacted, the next step is a transoral surgical approach. And this type you can see on this slide, that is a type of cell endoscopy, and that is of course transoral endoscopy. If the stone or cell leads are near to the duct orifice, of course it can be easily done without any complications. External shockwave lithotripsy is an option for not palpable stones or visualized under endoscopy. Intraparenchymal stones can be extracted endoscopically if they are 5 to 7 millimeters and visualized. Larger stones require treatment with transoral slitting. External shockwave lithotripsy is indicated for smaller stones that are not palpable and not visualized endoscopically, as I said, and if it generally unsuccessful for stones larger than 7 millimeters, surgical excision of submandibular gland should be as a last resort. Salivary stones within the parotid duct that measures less than 7 millimeters and are mobile require endoscopic removal. If endoscopic management is unsuccessful or stones have become impacted, external shockwave lithotripsy is considered the most appropriate second-line therapy with subsequent endoscopic removal of the fragment stones. Treatment of the salivary stones that do not respond to external shockwave lithotripsy is with combined transcutaneous and endoscopic approach, assuming the stone is visible under endoscopy. Surgical excision of the parotid gland should be last resort. The primary complications of cellular lithiasis are the development of cellular adenitis, acute or chronic, and atrophy of the affected salivary gland. Obstruction of the salivary glands may by a cellular leads block the flow of the saliva, resulting in the swelling and pain. Additionally, this blockage of the flow prevents the removal of bacteria and debris from the salivary duct, resulting in bacterial infection. If the obstruction is chronic, the blocked flow of the saliva will damage the salivary glands, acinar cells, resulting in a local inflammation. Without proper treatment, it can result in permanent fibrosis of the gland and atrophy. Removal of the large salivary gland stones, you can see one type of the procedure by extraoral approach or subcutaneous approach on this slide. Salivary gland stones most commonly occur in the submandibular gland, and it may be inside the duct or Warthin's duct because of its more mucous secretion and uphill flow. Large stones are usually removed surgically. Either an external or intraoral approach can be used. In this case, or in cases with marked inflammation, an external approach gives better exposure and aids in the preservation of nervous structures. Small stones less than 5 millimeters can be extended by dilation of the duct and the use of small microforceps. So, and let's see in this slide, you can see planned incision or marked incision. The next step, so incision is upper part, we can see platysma muscle inside the incision, and that the black color, that is hemostasis by electrocoagulation. In the next slide, in the branches of the forceps, you can see anterior facial vein, and of course it can easily be ruptured by scalpel, so surgeons can't use scalpel from this stage. Upper part or upper picture, we can see submandibular gland, and then removal of that gland attentively to the gland vein. Lingual nerve, the same. It can be visible and it can be easily ruptured by a scalpel or injured by a scalpel. So without any scalpel. In the last picture you can see a removed stone, as it was a clean operation or clean wound, so it should be healed by primary intention, and that means that we should do suturing. So the next slide you can see closure of platysma muscle, then closure of subcutaneous fat, and then the skin. For today that is all. The same. I hope that the lecture was understandable and interesting. We'll discuss all questions if you have in our practical classes. And for today, that is all. Thank you for your attention and bye-bye.